doing Facebook Live. I have no idea if this is actually reaching people. However, I'm just going to give it another minute since this officially starts at 6 and it is 5:59. Alright, I was just getting a notification that maybe my video frame is not right, but I think it's fine now. Looks like I have a few people joining, so that's exciting. And it is 6 o'clock, so I am going to go ahead and start. What I do want to let everyone know so far is that feel free to ask questions, type in questions. I will do my very best to keep up with comments. I'm going to be totally bluntly honest with everyone who is watching. This is my first time ever doing a Facebook Live video, so please bear with me as I get used to this new, I guess I shouldn't say new, social media's been around for a while. I just have been too busy to actually endeavor into this social media world, so here I go. My name is Jess Hebert, and I am one of the registered midwives working at Midwifery Collective in Essex County. If any of our viewers are our current clients and you haven't actually got to see my face, this is what I look like. As of course, during our appointments and as we're providing care, we have our masks on and our safety glasses due to our COVID-19 precautions. And this evening, what I'm going to be talking about is choice of birthplace. So I want to start out just by saying in Ontario, midwives are the only funded professionals who are able to provide care both in the hospital and at home, and in some communities in birth centers as well. Unfortunately, here in Windsor, Ontario, we do not have the option of going to a birth center. So we either have home or our Windsor Hospital or our Leamington Hospital. Both hospitals our midwives here have privileges at, so we're able to provide care during labor and delivery at all of those locations. For everyone that comes into care, we almost always talk about choice of birthplace unless it's already decided by the parents that they already have a very clear idea what they want to talk about, or where they want to birth. Sorry, but for the low risk healthy mom and babe, the research that was done right here in Ontario with midwives show that home birth and hospital birth are equally as safe. So when pregnancy is uncomplicated and when we don't have any risk factors excluding someone from home birth, then we want to offer that choice of birthplace to everybody, and ultimately everyone should birth where they feel the most comfortable and confident and safe, and we want to support that choice. And if we ever think someone's making an unsafe choice, then we would talk about that too. But at the end of the day, this is, the patient's pregnancy, their birth, their family, their baby, so they should be making the choice that's right for them, including where they have that baby. And for the low risk mom and babe, when you're in care with midwives, that you're going to get that choice between home or hospital. And it looks like I've got about 5 people watching, which is awesome. Let me see here. Okay. I'm just looking down the page. So one of the other things that I can chat a little bit about is this forum that we're starting. So this is the very first night that we're doing what's called Ask the Midwife, and each week one of the midwives in our group is going to do this live video, and we've already picked topics that we're going to be talking about. But really what we're hoping that this will be is a place for people to join in and ask any questions, whether they're in midwifery care, whether they're currently pregnant, planning to become pregnant, in between pregnancies, or just interested in the topic of midwifery and home birth for tonight, but just midwifery in Ontario in general. And if anyone does have any questions, that please comment. And if you're not able to comment, I'm sorry, I'm gonna have to try to figure out how to fix that. But what it looks like to me is that the comments are, it looks like, turned on. Oh, good. Okay, someone did comment, which thank you very much, because that tells me that it does work. And I can see that. So that was from Danielle. Thank you. Saying thank you, and thank you, Danielle. Perfect. So for people that have questions, even if it's not about home or hospital birth specifically, if you just even have some questions about midwifery, I'm happy to answer those questions. Please type them in the comments and I will address them as they come up. As I'm waiting for some feedback from people, I can talk a little bit more about some of the specifics about how midwives are trained in Ontario and what makes us appropriate care providers for both home and hospital birth. The midwifery program in Ontario is a 4-year Bachelor of Health Science, and the first year of that, the first year and a half, the first 3 semesters are all in class. We do our theory, our anatomy and physiology, our reproductive physiology, kind of all those pieces. We also learn our clinical skills, at least the introduction to them, and then from 4th semester, so 2nd semester, 2nd year and onward, we're in clinical placements in addition to doing online courses. So we have our online pieces of our course, but all of our practical skills are being done in a midwifery clinic or in hospital placements, and we have a combination of that. So our final year then is at the same midwifery practice with the same midwife teachers, and then by the end of that year we have the skills and the knowledge that we can enter into practice as a registered midwife. So for myself, I've been a registered midwife, it'll be 2 years this August, and I was lucky enough to do my senior student placement at Midwifery Collective of Essex County, after which I was hired on as a midwife. So I've got a few years experience just in this community, which is great. Part of our training, of course, is done in the hospital. We kind of go wherever our preceptors go, and so we get a combination both of doing home births and doing hospital births, and learning some of those differences. And what I always like to say is, a common question I get is how do we keep home birth safe in terms of the travel time between home and hospital, and we always take that into effect as we're assessing someone at a home labor, taking that travel time, the EMS transport into effect, and our threshold for things like transports to hospital is just lower than if we were already at the hospital. So we're always thinking about those pieces. That's just part of the mindset that we have when we are managing a labor at home. The other thing that we do is we have a grant that we're given from the government when we first become midwives, and we use that grant to purchase all of our home birth equipment. We actually carry with us in our cars all of the same equipment that a level 1 hospital has, including everything we would need for a full neonatal resuscitation. Now, thank goodness I have never had to do a neonatal resuscitation at home, and part of that reason is because we also screen our clients carefully going into home birth. So anyone who is planning home birth is a low risk person, that we don't advise home birth for someone who has risk factors or is a high risk individual. Then we would be recommending hospital birth, in which case we would still be providing their care but in hospital instead of at home. And for someone who's planning home birth, we also will see that client at home prior to delivery, usually around 36-37 weeks of pregnancy, and we look at their space, talk about the space that we need to set up our equipment, and just make sure that the space is adequate and appropriate. Make sure that they have what they need, we have what we need, and then we just wait for labor and wait for a baby. And I've got to definitely admit that I'm quite biased. I love home birth, but ultimately the most important thing for me is safety, healthy, happy, safe mom, baby, and also that our women feel confident and comfortable and happy with the choices that they're making in choosing their birthplace. I really could ramble on all evening about midwifery and about birth, but I would be really pleased to answer some questions and kind of gear the discussion toward what people are actually wondering about. So maybe I'll just give everyone a couple of minutes, and if some people can come up with some questions to post in the comments, then I'm more than happy to answer that. In the meantime, I guess I can also say that if you're wanting to learn more about home birth or about midwives in general, you can always visit the College of Midwives of Ontario website. which I can post in the comments as well. You can also visit our Association of Ontario Midwives website. And I'll just grab those and post them for people to look at. Oh, great. Danielle, I see your question here. Sorry, there's the College of Midwives in Ontario website. Oh, I love the questions coming through. Give me 1 second, guys. Let me just get my association website here. Ontario Midwives. And the AOM website that I'm about to post in the comments, they also have put together a little video about home birth that I like to show at all the home birth information nights that I am a part of with our practice. We do them every few months, and you can find the home birth section on the AOM website. You can also find the video on YouTube, and it just gives a really nice kind of overview of the research and why someone might choose home birth. So let me start out with answering Danielle's question, which looked like it was, could you have an OB and a midwife? And the answer is yes. Sometimes when clients come into our care, things don't start complicated, but then complications can arise during pregnancy. For any of our viewers who have been pregnant before, have known anyone who's been pregnant, and even when you haven't had that personal experience, we all instinctively know that pregnancy and delivery are not, they're no hard and fast rules. They are unpredictable, and unpredictable things can happen, and complications can suddenly arise. And so much of our job is assessing, and really looking to make sure things are staying normal, and when things do step outside of that box of normal, as I like to call it, that we do want to intervene. And sometimes, most of the time in pregnancy, if we do have a concern, then what that means is involving an obstetrician in your care. If you are already in midwifery care and we need to involve an obstetrician in your care for whatever reason, you do not lose your midwives unless you do not want midwives anymore. So depending on what the complication is, we might just be working with the OB and still doing a lot of your care. Or if the issue is too complex that your care would need to be transferred to an OB, then the midwives would remain involved, but we call supportive care. So we would still attend your birth, we would still come see you at home for home visits in the postpartum, help you with breastfeeding, whatever we can do to help on our end. But we wouldn't be doing the main clinical part. That would be being done by the OB in a transfer of care situation. So in that way, some clients do end up having both an OB and a midwife, but there is only ever one provider that is making the medical decisions, so to speak, if that makes sense. And then, but the bottom line is that if you come into midwife care, you do not lose your midwives unless you don't want midwives anymore, that we do stay involved. And the only time that we would recommend someone go to an OB instead of midwives is if you did apply for care, and if we found out from your initial kind of assessment through our administrative staff that your health history is too complex for midwives, then we might recommend that you do go straight to an OB. The really nice thing in our community is that even if your care would be too complex for the midwives to handle, and that you would need an OB right from day one, our practice owner, Andrea Cassidy, actually runs a program called Expecting and Connecting, and she kind of does the midwife side for patients who are under OB who are too complicated for midwives as their primary care provider. And one of the big things that she does in that program is does the breastfeeding support, does postpartum home visits, does phone assessments, phone help, and really gives patients that kind of extra piece that they don't get from their OB, because that's just not part of the obstetrician's scope to do that breastfeeding and that supportive care piece. So we also have that other program, Expecting and Connecting, that we can refer people to that are maybe too complex for midwives and would need an OB care through their whole pregnancy. And then I see another question here, is if someone is having twins, would a home birth be possible? And that question's from Monica. Hi, Monica. And to answer your question, I want to say that in theory, yes, it would be possible, but in our community, we don't recommend home birth for a twin delivery. We recommend a hospital birth because as unpredictable as a singleton, as one baby birth can be, twins even more so, that there can definitely be sudden complications as the second baby is delivered or comes down. And even in the case of the most uncomplicated twins, which would be each twin having their own sac and own placenta, even in those cases, we would still definitely be recommending a hospital birth. And that being said, for someone who's hoping to have as much, like, to respect the natural physiological process of birth as possible, if you're having twins, even though we don't recommend a home birth, we've cared for lots of clients who are expecting twins. We would just, as I mentioned before, have an obstetrician involved, and both the obstetrician and the midwife work together to take care of that person, and we still go to the birth and help you with babies and all those pieces. So just because you're pregnant with twins does not make you inappropriate for midwifery care. You can still have a midwife, but we would recommend having an obstetrician involved, and we would be recommending a hospital birth if you're expecting multiples. Let me see here. I think I'm caught up on questions so far. Oh, good. I've got another question from Ashley. Is it normal to have a primary midwife and a second midwife? Do they consult it all together for the mother's care, or just use notes at the time of appointment? That's a great question, Ashley. So please feel free to comment again if I'm not quite answering the question that you're asking, but I think that I have kind of two answers. If you mean, is it normal to have two midwives instead of one midwife at birth? Then the answer is kind of yes and no, actually. At Midwifery Clinic of Essex County, at our practice, we do a combination of having a second midwife come and join the primary midwife at delivery, and sometimes we also use nurses as our backup midwife, and they'll come in and assist us during the delivery part, and then when things are good, baby's good, mom is good, the nurses will go back to their other patients, and the primary midwife will just continue with the immediate postpartum care. The other piece maybe that you're hinting at in your question is, at our practice as well, we do what's called a shared care model, which means there are 5 on-call midwives, myself, Tara, Diane, Corey, and Abby, and you hopefully you've all gotten a chance to maybe look at our page prior. Some of us have posted videos, and some of us have just posted like a picture with kind of a written explanation, just a little bit of a bio for each of us. And we do what's called shared care, like I said. So what that means is we all share the responsibility of caring for everybody. And even when you're seeing different midwives at different appointments, because we all do what we call handover, so each week we meet, and if there's anything in particular that needs to be handed over, that we want to draw our colleagues' attention to provide the best care possible, then we do that. So all the midwives are always aware of anything in particular going on with certain clients. And ultimately we all use our Ontario perinatal record, the same system that OBs, family doctors, anyone taking care of pregnant ladies use, and we all document every appointment on that. So even just in the written record, we can all see the care that each other has provided. But we all stay in really close communication to provide comprehensive shared care. So that's kind of how we all care together for everyone. Because we have 5 midwives, we've split ourselves up into teams so that whatever team you're on, those midwives are more likely to be at your birth, but it actually could be anyone, so we try to get everyone to meet at least 4 of the 5 midwives. And I hope that makes sense, Ashley. Please feel free to ask more questions so I can clarify further if that isn't enough. Monica, are you guys comfortable attending a pregnant mom? So, Monica, that's a great question. Monica's asking, what would the midwife's comfort level be for a mom who's not wanting any surveillance during her pregnancy? So that would be like declining ultrasounds or any like Doppler fetal heart rate checks. And Monica, that's not a question I get very often, but a really great question. And what we would do is for someone who was pregnant and coming into care and had that request, we would have a really good discussion early on in the pregnancy about what ultrasounds are recommended and why. And after all that information has been laid out, if the patient's decision is still to decline any ultrasounds or Doppler assessment, I would for sure offer assessment of the baby with the fetoscope. So that's the it's sort of like a stethoscope, but instead of the end being the normal circle, it's sort of like it's almost tubular. And instead of the Doppler being used, that I would offer to listen to the baby with that instead, because then I could still listen to the fetal heart rate and assess the baby's well-being via the fetoscope. Which again, like I said, is similar to a stethoscope, just meant for listening to a baby on the inside. I would definitely be offering that. And then, but otherwise, just because something is routine and standard and recommended, it doesn't mean that you have to do anything. And when that good discussion has been had, you get to pick what is right for you or for not. So it's really not about my own comfort level per se. It's really more about, if a woman understands the risk that she's taking by declining, particularly the second trimester anatomy ultrasound, and specifically for placenta location, but that's something we would be talking about in clinic. If someone is choosing to decline that, then that would be her choice. Again, I want to preface some of these things I'm saying to say that this is not medical advice, and if you did come into care, or anyone who comes into care rather, that person's care is individualized, and the plans and assessments that we do for every single person are individual to that specific person, and the conversations that we have, the plans that we make, would be individual to that specific person in that case. So it really just depends on what's going on with that particular mom, what her background is, what her health history is, what her risk factors are, and that would be taken all into that discussion. But for sure, at the very least, what I could guarantee is informed choice. And if we think you're making an unsafe choice, then we're going to be telling you about that and telling you about those risks. But ultimately, everyone gets to take on the risks that they're comfortable taking on. And what we would do is we usually create like consent forms and explicitly write out what we've talked about, and then everybody signs it, really. And the reason that we do that is because, most importantly, we want to protect people's autonomy in their health care. But again, this is not medical advice for any general person, and I definitely want to be really careful about when we're talking about when people make choices outside what we would consider the standard of care. But people do make those choices, and I believe it's safer to be able to discuss that with a healthcare provider, and be able to know all the information before making those health decisions. So what my advice would be is, if you are pregnant or thinking about becoming pregnant, and when you want to talk about all of the options, come and see us, because that's what we're going to talk about. We're going to talk about all the options, and we're going to give you all that information so that you can make that informed choice decision. And again, like I said, this is not health advice for everybody. I can't actually make a plan for any particular person until they're actually in our care and we're looking at their whole clinical picture. I'm really loving the questions, guys. This is lovely. And hopefully the information I'm providing is at least somewhat helpful. Coming up, while I'm having a little bit of a break from questions, what I will say is, every Wednesday at 6 p.m. we're going to do an Ask the Midwife video, and it's going to be a live feed. And I want to, next week, I believe that our head midwife, Andrea, is going to be talking about breastfeeding and breastfeeding questions. Let me double check that, guys. Yep. Pretty sure. Let's see here, 1 week. Yes, that's what's going to happen next Wednesday at 6 p.m. at 6 p.m. but on Facebook Live. That Andrea's going to be talking about breastfeeding and breastfeeding questions. And Andrea, like I said, is the midwife who's our practice owner and also runs that Expecting and Connecting program. So everyone can bring some questions about that as well. Monica, yeah, Monica, if you have some more questions, feel free to ask here, and depending on where you are at in your own personal journey, you can also call our office and get some more information that way as well. One thing that I really love about being a midwife is kind of things like this, is that being able to do the education part and watching families and women learn through their pregnancy is, I find that very satisfying, and seeing a mom go from, first pregnancy and maybe a little bit nervous, a little bit anxious, not really sure maybe how to go about this journey and making all these decisions all of a sudden, going from that to this confident mom who is, confident to ask questions and confident to do research and be able to make those decisions not only for herself but also for her newborn. It's wonderful. Okay, Monica. Her question is about delayed cord clamping, so if that's something that we do, and then she's also asking about lotus birth. For those of you that don't know what lotus birth is when after a baby is born, the cord is not clamped or cut until after the placenta is delivered, so everything remains intact. I don't personally recommend lotus birth, and the reason that I do not do that is that I've read some research that talks about how the cord gets cold after it stops pulsing, and that can make the baby cold, and I don't like cold babies. We want to keep those babies nice and toasty, so that's not something that is routine practice. However, just like anything else, if someone was requesting that, again, we would look at that clinical picture and have that full discussion of is this something that mom and dad are gonna do, even if we're not necessarily recommending that, and just kind of talk that out all the way. But that's a little bit of the research that I'm familiar with. However, delayed cord clamping is absolutely part of our routine and standard of care, and it's actually standard of care in the hospitals as well. So even for patients who have obstetricians and have their babies under OB, that I want to say it's part of the Friendly Baby Initiative in Ontario, and part of that is delayed cord clamping for everybody. So for myself and for the midwives here, as long as your baby is born pink, or as long as a baby is born pink and screaming, and there's no concerns with that baby's transition from womb to world in those early minutes, then what we do as a standard is let the cord pulse until it's done pulsing, and then at that time we would clamp and cut the cord and officially have a baby on the outside, not connected anymore. And what we also know from the research, that delayed cord clamping does help babies transition, because it allows them to get that little bit of extra oxygenation from the blood that's still coming through that cord. Oh, and I'll just say that if a baby came out and we have concerns that the baby needs a little bit of help, needs some extra rubbing, or needs any kind of help to start breathing, crying, that would be a medical, clinical reason where we would not do delayed cord clamping. We would want to get that baby to assessment right away, usually on a flat surface next to the delivery area, whether that is at home or in hospital. In hospital, it's usually a warmer beside the bed, but at home it's wherever we've set up our neonatal resuscitation station. And in that case, what we would try to do is at least milk the cord, which is when we kind of push the blood into the baby before we clamp and cut to get that baby to assessment. If there's time for that, then that's something that I would try to do. Patricia has a question. What do you know about saving the cord for future use regarding stem cells? Also a great question, Patricia. So in our community, some parents will choose to do cord blood banking. What parents do is actually you kind of sign up with a company that will then store the cord blood for you long term. Again, this is, I don't know a whole lot. I have not had the experience myself of having to do cord blood banking for a lot of patients. So I've only maybe been involved with one patient, and they decided to do that. So I'm kind of just speaking from memory and from what I understand about the process. So please forgive me if the information is not perfectly accurate. But from what I understand, it is there's like a kit that you order from the company, and you basically enter into a contract with that company because then they're going to go ahead and store the blood. You have to have the kit prior to delivery so that you can bring it to the hospital or have it at home, whatever the case is going to be. The kit comes with the instructions both for the parents and for the healthcare provider in terms of how to handle the cord and how to like prepare it for storage. Then it either gets picked up or sent off. I guess either way, that's kind of the same thing. Back to the company, and then it's stored for whatever the agreement is, I believe. So if parents are wanting to do cord blood banking, then that would kind of be on them to organize, and they just need to let us know and have the kit ready, and then we can just follow the instructions for that. Hey Shauna! Hi there! I see your question here. So Shauna's just asking about, at our practice, what is going to be our protocol for as things open up. Sorry, let me preface this by saying during the height of the pandemic that sometimes what we would do is do some in-person appointments with our patients and then also do some phone appointments just to reduce everybody's risk of exposure and really only see them as absolutely essential versus the routine prenatal schedule. We see them more often compared to what we considered a reduced prenatal schedule based on the World Health Organization recommendation for when people absolutely should be seen in person during a pregnancy. So with that said, Shauna's asking if we would still be offering phone appointments for those who might find it difficult to get into clinic in person for every single appointment. And what I'm going to tell you, Shauna, and everyone who's listening is that we continue to make everyone's appointment schedule something that will work for them while still maintaining the essential in-visits. So I definitely have been still doing virtual appointments, and sometimes in the case of a client not being able to either have childcare because we're not allowing children in our office at this time, except for the newborns, of course. But sometimes when childcare falls through or transportation falls through, then we've definitely been doing virtual appointments on the phone as well as in-person appointments, and we just continue to make sure that we are seeing our clients at least at those essential times through the pregnancy to keep those in-person assessments. That's also going to be different for every person. When a pregnancy is low risk and uncomplicated, it's perfectly safe to use that reduced schedule for prenatal appointments. However, when there are concerns or if there's any risk factors or we have a concern that we would want to see you in person more regularly, then we would make that recommendation and make those arrangements as well. So it still is going to depend on everybody's own particular clinical situation as to what we plan for the appointment schedule. But we definitely are moving more towards seeing people on the routine schedule, which would be seeing you every 4 weeks in person in clinic from when you come into care until you're 28 weeks pregnant, and then seeing women every 2 weeks between 28 weeks pregnant and 36 weeks pregnant, and then seeing women every week until they have their baby. Sorry, I almost accidentally ended the live video, but I didn't. We're okay. I've got to take a little minute, guys, and brag for 1 second to pat myself on the back that I actually got this up and running and comments are working. And I gotta say, like I said at the beginning, I was a little bit nervous about all this Facebook Live stuff, but it's going okay. I'm gonna be happy to report to my fellow midwives that they'll do just fine. Monica. Hi, Rola. Hi. Um, Monica, you're asking whether or not midwives are comfortable attending a birth where parents don't either. You're asking that they don't vaccinate either themselves, their children. Either way, whether or not you choose to vaccinate, of course, from a healthcare perspective, we recommend that children are vaccinated per that routine schedule. But as parents, you get to take that decision yourself. And as currently right now, regardless of the amount of COVID-19 vaccinations that have been distributed and administered, we are still abiding by all the COVID-19 precautions. So when we do care, like I mentioned before, we have our mask on, we have our goggles on. If we're doing a home birth, we wear obviously both those things. Plus, we usually wear a gown just to protect our clothes from any spray, anything like that. And we care for a variety of people who make a variety of choices when it comes to vaccination. But I will say that that again, really like any recommendation, even though we're making that recommendation, everybody gets to choose what they want to choose. And if you're comfortable taking on the risk, then that is your comfort level. And in terms of our comfort level, we have the PPE to protect ourselves. We ask people who are not the laboring woman to also wear their mask, unless we're in a separate room. That's something else that we've been doing. So we take appropriate precautions on our end as well. And it's just more kind of another question, Monica, that we would be talking about more in clinic and looking at that whole clinical situation and determining what is the best, safest plan for our patient, for their baby, and for the midwives as well. Emily, your question is how can someone relieve sudden pain in the pelvic area when coughing or sneezing? So Emily, unfortunately, I don't know that I'm going to be able to give you an answer, only because I haven't been able to do a full assessment of what may or may not be going on with you. If you are currently in our care, please feel free to call our office and speak with a midwife or ask at your next appointment. But if you are not in our care, then I would definitely recommend that you direct any medical questions toward your family physician. The only thing that I could recommend in terms of without providing you care, because I can't legally do that, obviously, if you're not in my care, but something that that is safe, whether you're pregnant or not pregnant, is pelvic floor physiotherapy. And that's something that can be done anytime in a woman's life to assess the health of your pelvic floor. I don't know whether or not that would be helpful or not for you specifically. Again, like I said, I can't give you an answer without doing a clinical assessment of you and of your whole situation, unfortunately, so I'm sorry about that. But I'm hoping that either you can direct that question to your family doctor or to your midwife if you do have a midwife currently, and that hopefully we can get an answer for you. Ayana, I hope I said that right, but you have asked, so Ayana, you have twins. Like I'm taking it that you've already like delivered your twins. Your twins are on the outside, it sounds like, and it sounds like, oh, sorry, I'm so sorry. You're replying to Monica, and I did not see that part of the comment. If you are, I can tell you guys for sure, if you are expecting twins, and you call our office and you're wanting to apply for midwife care, we have definitely taken in mums expecting twins in the past, and I don't know if you're going to get that same answer from your family doctor, but but you could also be rest assured that we would be involving an obstetrician in your care because there is that higher risk factor of having multiple pregnancy. But a really nice thing as a midwife is to be able to provide the extra support that you do need with two babies, as I'm sure any parents with twins out there know that it's I want to say different. Having a baby, no matter what, is going to be a challenge, but having twins is a different kind of challenge for sure. And especially if you're hoping to breastfeed those babies, that often requires help and support. Breastfeeding one baby already requires help and support. And if you have breastfeeding questions about twins, please keep a note of them and bring them to Andrea next week on our Ask the Midwife, because like I said, she's going to be talking all things breastfeeding. I also want to address, Ayana mentioned just that she felt some pressure to make certain decisions during her labor, it sounds like, at the hospital, and I'm so sorry that you felt that way. Unfortunately, there's just sometimes when care providers mean well, that well-meaning, that recommendation can come off not the way it's intended to, and in not a way that makes women feel good about that. So I'm really sorry for that experience, and I hope if you have more babies that that it goes better. If you did have an OB previously, especially if you have a singleton pregnancy and you did want to have care with a midwife, then I encourage you to apply for care, and hopefully it can go better in the future for you. Wow, 11 people. I mean, that might not seem like a lot, but I was maybe thinking that 2 or 3 people would be joining me tonight. So I'm quite pleased to have double digits. Again, please feel free to put your questions. I'm loving everyone's use of the comments. This is awesome. There are no silly questions. I say this to my patients all the time. That just there's always something new to learn, no matter how many times you've been pregnant or how many children you have. I mean, even as a midwife, we're always learning because pregnancy and birth are sort of always evolving in some way, and we definitely don't know everything there is to know about pregnancy and birth. Monica's asking about the midwife's skill in using abdominal palpation as opposed to ultrasound to determine the size and position of the baby. So definitely, the more experienced you are as a midwife, the more, I think, like, it's almost like the more intelligent your hands become. And even in the last 2 years of being a registered midwife, plus my time as a student, I've noticed kind of that even progressing further. So even just in that short time, I'm already telling that difference of being able to, being able to figure out how baby is sitting faster than I could, a year and a half ago. So I would say that at least for me, it's kind of a constantly evolving process. And we always palpate everybody's belly at every appointment and try to determine how we think baby is sitting. If we are unsure about baby's position, particularly whether or not the baby is head down, and particularly if we're not sure or if we really suspect that baby is not head down at around the 36-week mark, then what our routine practice is to confirm with an ultrasound. And if a client did not want that, then again, at that time, we would look at that whole clinical picture, have that discussion, and make a plan with that particular person about what the recommendations would be based on that decision, or if a different decision is going to be made. And in terms of size of baby, position of baby is one thing that our hands are pretty smart at. Size of baby, even an ultrasound can be a pound to pound and a half off, although I do find that they're fairly accurate in our community. At least the last few babies that I've been at the births at who had recent ultrasounds were pretty accurate, but we never know for sure how big a baby is until that baby comes out and we put them on the scale and actually get the poundage and grammage, I think that's the word, of how big that baby is. The other thing that we do is we measure the uterus from the top of the uterus to your pubic bone, and we call that the symphysis, that's the pubic part, fundal, that's the uterus part, symphysis fundal height. And we measure that at every appointment as well, and we know the normal limits of that measurement compared to how many weeks pregnant you are. And if your measurement is outside the normal limits, then we again would be offering an ultrasound and talking about the implications of that at that time. The other thing I want to throw out there is that midwives are covered by OHIP, and if you do not have OHIP, you can still come to a midwife without having to pay. There may be like a copay for any lab work or ultrasounds, but part of that is funded when it's ordered by a midwife, even for someone who does not have OHIP. And for someone who does have OHIP, we are completely funded by the Ministry of Health. So that's just something that I like to say, because a lot of people don't realize that. So yeah, just to put that out there. Monica, you're very welcome. Well, we've just got about 15 minutes left before I end the session. So if anyone has any final questions, please bring them on now. And otherwise, I mean, if everyone's kind of asked their questions and they're happy, if the only thing I'll say is that if anyone has joined late and would actually like me to kind of rehash the choice of birthplace piece, then please let me know in the comments, and I can do that before I end our session tonight. I'll give it a couple of minutes, and then if everyone's good, then I'll say my goodbyes. Oh, we do have another question. Kelly is wondering, what is the difference in the model of care between an OB and having a midwife? Kelly, that's an awesome question. And the biggest difference, in all honesty, is probably that we get to spend more time with our patients than OBs do. So because of the way that we're funded from the ministry, we have the luxury of only being able to take a certain number of people into care every year. And because of that, we get to have half an hour to 45-minute appointments with every single person every time they come in. So we have time for the discussions that we have, versus OBs have a lot more patients than we do, and unfortunately, because they have more people to take care of, they just don't have the time to actually sit down with their people. Now, of course, they take the time when the patients need it, but as a midwife, we really have the luxury of actually just being able to take that time with every single person and have those discussions and answer those questions. And then what we'll often do too is, let's say that someone has extra questions and we're going kind of past our scheduled appointment time, then we can always arrange to do a phone appointment later that week, later that day, and get those questions covered and do that education piece. So we get to do not only the clinical care, because we are trained clinicians as midwives, but we also kind of get to do the prenatal education piece as well in that labor and birth preparation. And then another big difference between midwives and OB is that the OB scope, it includes gynecology, which we don't do a lot of. We do pap we'll do pap tests for our patients when they're due, and we can do a pelvic assessment, but we don't diagnose gynecological issues. We don't really do anything past that in our scope as midwives. But for an OB, in terms of a obstetrical scope, they care for everyone from conception to delivery. But at the time of delivery, if you have an OB, when your baby is born in the hospital, the baby gets admitted under pediatrics and the mom stays admitted under the OB. So the baby and mom are in two kind of separate, they're in the same room together, oh my goodness, they're in the same room, but they're under two separate people. Whereas for a midwife, we care for you all during your pregnancy, And then we also care for you during your labor and delivery, and then we also continue to care for you and your baby, being the primary care provider for both you and your newborn until the baby is 6 weeks old. So even though the baby is born and is outside of your body, especially if you're breastfeeding, the baby's body and your body are still working together. So we still treat you like a unit even after your baby is born. And that's something that's really special to midwives, and that's kind of part of one of our tenets of care, which we call continuity of care, because we continue to care for you from as soon as you come into midwifery care when you're pregnant until your baby is about 6 weeks old. And of course, we care for your baby as well in that time. For home births, Monica's wondering if what happened here? Sorry, there we go. Something popped up in my computer screen. Sorry about that. With home births, do you find a lot of people don't use intervention? So, when someone is planning a home birth and when they have a successful home birth, meaning the baby actually is delivered at home, there's no option for an epidural at home. We do not do that at home. The only kind of pain relief that we have at home is water, like people can get in their bathtubs. We do not advise birthing in the bathtub because we don't have good enough access to you in case of an emergency in a household tub. But lots of women will get in the tub or in the shower just to get through contractions and then kind of come out and have a baby. And in terms of other intervention, we monitor the baby. We listen to the baby either with the fetoscope or with the Doppler every 15 minutes, and that is our routine protocol. When pushing commences, we listen every 5 minutes. If we have any concerns, we talk about that. If there's time, if it's an emergency, then we are going to just take care of you, and we always debrief after the fact. But in terms of other intervention, there really isn't a lot of intervention to be done at home, to be completely honest. I think the most intervention that can be done is sometimes when mums are, if we're thinking that maybe things are progressing a little bit slowly, we would offer to break your waters. Sometimes mums request their waters to be broken to speed things along because they just want to be done a bit sooner. Sometimes that works, sometimes it doesn't. And just like I've said a few times now tonight, for every single person, we individualize that care and make a plan specific to that person. So every birth has a lot of the same elements, but every birth is different as well. For each person is different. Oh, Stephanie, thank you. Stephanie just gave a shout out, just some love for the midwives. I appreciate that, and thank you for that, Stephanie. Hello, and I hope you're doing well, and thanks for joining us tonight. Patricia, I believe the video is going to be recorded and posted on our Facebook, but I really don't want to make that guarantee. If this one is not posted, then our future ones will be, because we'll correct that issue after tonight. But it's my understanding that it will be posted. Again, I'm sorry that I don't know that for sure. If this one has not been recorded, if there's something else that I needed to do to make that recording happen and I just wasn't aware of that, that will be corrected for next Wednesday, and our future Ask the Midwife videos will be recorded. I mean, the best way to know is once we're done, feel free to go on our page and see, and know that if the video doesn't show up there in the future, they will, because we'll correct that problem. But it's my understanding that it will be there. All right. I will take any final questions. Oh, they are still coming. Okay, great. Kelly is asking, how do we tell as midwives, as we're assessing someone laboring at home, how do we tell if and when we should transport into hospital? Kelly, that's a great reason, and great question. And my short answer is, if anything is stepping outside of what is the normal limits of labor. So some examples of that would be if we if as we listened to the baby, we heard something that was concerning, if the labor was not progressing at a normal rate. And that's not to say that we put anyone on a clock. We definitely don't practice care in that way, but the research tells us that there is a rate of labor that is slower than normal, that is normal, and faster than normal. When things are faster than normal, we're not too worried about that, because babies that come fast, we don't worry too much about. But sometimes babies that take a long time to come, that sometimes those babies have a harder time once they're on the outside. So we want to try and prevent any issues that those babies could have. I would say the most common reason that I've transported in with mums in the past is for pain relief and exhaustion. That they're needing the epidural to get some rest so that they can gain some more strength before they actually have to push the baby out. And I've found that when I have transported in for that reason, or when another midwife has transported in and I've resumed the care of that person, that sometimes that's exactly what that person needs, and then goes on to have a lovely delivery in hospital. So just because we start a labor at home, we don't always finish the labor there, but it also doesn't mean that the labor is not going to be any less, or the birth is not going to be any less lovely. There are kind of a whole slew of reasons that we could be recommending transport into hospital from home. And if you come into care with us, and if you are planning a home birth, we go through that in a little bit more detail with each person. But I think what I'd like to stick with is really, if things are not going normally, if they're not within normal limits, and they're not in that low risk kind of box of normal, box of low risk, then we're going to be recommending transport in. And as we assess someone, I mentioned this earlier as well, part of our training and part of our philosophy of practice, part of the way we keep home birth safe, is that we are constantly doing that assessment and making sure that we are still safe to remain at home, and we are also taking into account the time it might take to transport from home to hospital, whether that's in your personal vehicle, if we're transporting in for a non-urgent reason, or if we're going to be going by EMS, if the reason that we're transporting in is more urgent. And I've had both. I've transported in an ambulance. I've transported in like mom and dad go in their car, and I go in my car. Most of the time I go in my car, but if it is urgent, then I will often travel in the ambulance with the patient. Monica, I think this is going to be our last question, everybody. Monica's asking, for home births, do midwives teach positions, breathing techniques, or is that something that women are kind of expected to learn themselves ahead of time? And the answer is actually both, to be honest. We always talk about coping with labor, and we talk about where to look for information about learning potential coping techniques. We talk about those techniques prenatally, so leading up to the delivery and your pregnancy appointments. And then during labor as well, I want to emphasize that midwives are not doulas, because we are a clinical care provider, so we're doing all of the clinical care. But in addition to the clinical care, we also provide the labor support as well. Some clients choose to have a doula in addition to their midwife. We work excellently with doulas. Doulas are not covered by OHIP, so for people who want doulas, they do pay for that service. But doulas are the people that only do labor support. They do not do anything clinical. But as a midwife, we do both. We kind of get to wear both of those hats. So even during labor, sometimes we palpate baby in a certain position, and that's going to cue us to say, you know what, why don't we try this position for a few contractions? Or why don't we, one of my favorites is, why don't we go sit on the toilet for a few contractions? Women don't love me for that, but it helps. I wouldn't recommend it if it didn't. And we kind of gear different positions in labor based on how we think you're doing, how we think you're coping. I'm one of my support techniques that I use personally is I like to talk women through their contractions and just encourage them to do that breathing. I'll breathe with them and just kind of get their focus back centered to center themselves, and I find that sometimes I can be helpful in that way. And really, again, I know I've said this a lot, but we really try to individualize our care and try to give women the suggestions that are going to work for them in that moment, in that labor, and provide care in that way. But we definitely also do give you some resources, give you either like evidence-based research websites to look at in advance, so that you do maybe can come up with some of your own ideas of what may or may not work for you during your labor. Whether you're planning home or hospital, we always talk about labor preparation, because even if you're planning a hospital and even if you're planning an epidural, I can never guarantee that you're going to be able to get that epidural right at the moment that you want it. The anesthesiologist may have another case that they're presiding over that they just can't get away from at that minute. There could be a more medically urgent case than an uncomplicated labor, and that's definitely happened, and sometimes we have to work through more contractions than we're expecting without pain relief. So we always talk about labor preparation, and so much of labor happens in your psyche and it happens in your brain. So the only thing that doing that preparation can be is helpful. So we try to talk about that. We talk about that with everybody for sure. So that brings us to our full hour. I am so pleased with how this went. Thank you so much, everybody, for joining tonight. If you have more questions about midwifery in general, and especially about breastfeeding, please join us next week on our Facebook page for Andrea's Ask the Midwife about breastfeeding, and then every Wednesday going forward, we're going to have a live session, our Ask the Midwife session. A different midwife will do it each week, and we'll kind of cycle through, all of us midwives taking turns talking about different things and answering your questions most of all. If you are planning on becoming pregnant, or if you're wanting more information about midwives, please visit the websites I posted earlier, the College of Midwives of Ontario website, also the Association of Midwives of Ontario website. You can see our information on our Facebook page. We've also got a website, which I can link here as well. It's just midwiferycollective.ca, and you can see our pictures on there. You can see a little bit more information about us and how we work. You could also call our office if you're wanting more information than that. And if you are wanting to come into care with midwives, if you are pregnant, then you can find our care application form on our website. I can post our website in the chat. Apparently I can't spell. There we go. Everybody can't spell at one time or another. Here we go. Okay, there's our website. All right. Oh, thank you so much for the compliments, guys. That actually makes me feel really good, because I was kind of nervous about tonight, to be perfectly honest. It is my understanding this is going to be posted both on our Facebook and our Instagram. And I know it's in the works to have a YouTube channel started for our practice as well, so hopefully we can kind of link everything together, and that way the information will be out there. Again, I want to say that this is not medical advice. This is just information that I hope everyone has found helpful and is quite particular to our community and to midwifery in Ontario. If you do have health questions, please address them to your current care provider, whether that is a family doctor or a midwife or an OB, depending on your situation. And I hope to see you all again next time I'm doing Ask the Midwife, which is probably going to be about 5-6 weeks. And I hope that you guys join again in the future on Wednesdays at 6 p.m. for our Ask the Midwife. Thank you so much for joining me tonight. It was a pleasure answering your questions, and I'm looking forward to seeing you all again. Have a good night, everybody. Bye.